Welcome, everyone, and thank you for participating in today's webinar of the Get the Medications Right Institute, Alternative Payment Approaches for Advancing Comprehensive Medication Management in Primary Care. My name is Katie Capps, and I'm the co-founder and executive director of the Get the Medications Right Institute. On behalf of the Institute, we are delighted that you have joined us today. Now, I'd like to give you a little bit of background on the Get the Medications Right Institute before we get started. For those of you that have joined us on the call today that are not familiar with the Institute, we launched in April of 2019 and have built a coalition of over 1,400 individuals from close to 900 companies from throughout the United States. Our focus is on enhancing life by ensuring appropriate and personalized use of medications. We do this through 4 key areas. We concentrate on practice and care system transformation, payment and policy solutions, precision medicine via advanced diagnostics, health IT to support optimized medication use. Now, the Institute is funded by those organizations that are listed on this slide. The board of directors is comprised of the individuals that you see here, and we are very thankful for the support, not only of our board of directors, but the companies that help fund the Institute as well. I think it's important to let the audience know that the Institute is grounded in 5 very important belief statements. We believe that a personalized and patient-centered and systematic and coordinated approach to medication use will vastly improve outcomes and reduce overall healthcare cost. But we've got to align systems of care to integrate comprehensive medication management. We also need delivery system, payment, and policy reform. It's important that there's appropriate diagnosis and access to advanced diagnostics with companion and complementary testing in order to target correct therapies as part of the CMM process. But most importantly, we believe that this is best accomplished through team-based, person-centered care models that recognize appropriately skilled clinical pharmacists who work in collaborative practice with physicians and other providers. We all know that there are a lot of medications on the market today, and there's just too little time in our current fee-for-service environment. Medications are involved in 80% of the way we treat and prevent illnesses. There are over 10,000 prescription medications on the market today. And unfortunately, in our current environment, with limited time to see patients, only about 49 seconds is spent on talking to patients about their new medications during a 15-minute visit. There are all sorts of consequences of the fee-for-service environment that prevent us from appropriately managing medications throughout the continuum of care. The medication therapy problems are vast, but they are driving waste and they are driving quality issues. The cost of non-optimized medication use has been calculated to be as high as $528 billion a year, driving costs to additional hospitalizations, ER visits, additional physician visits in order to fix problems created by medication problems, and long-term care visits. Now, we'll talk today about comprehensive medication management. At the Institute, we believe how we practice matters, and how we practice determines our ability to optimize medication use. We believe that that is best done through comprehensive medication management in practice. We've outlined a 10-step process for comprehensive medication management that relies on technology, not only to evaluate those that have not achieved the clinical goals of therapy, but also to ensure that all team members have access to clinical information to determine whether clinical goals of therapy have been achieved. Use of diagnostics is also important and should be part of the CMM process. And then finally, and most importantly, how we pay for care matters. It has an impact when we are looking at interprofessional team-based care, and you will hear more about this from our 2 presenters today. We have found that there is a significant return on investment of of applying comprehensive medication management in practice, and that is well documented. It's also well documented that application of CMM as a process of care to optimize medication use will improve clinical quality. There's cost savings associated with that, patient outcomes, and physician satisfaction, in addition to patient satisfaction. You'll hear more about that today from our two presenters, and I'm delighted to introduce both of them to you. We'll start off with Dr. Katherine Pham. Kathy's the Director of Policy and Professional Affairs at the American College of Clinical Pharmacy. The American College of Clinical Pharmacy is a professional and scientific society that provides leadership, education, advocacy, and resources, enabling clinical pharmacists to achieve excellence in practice, research, and education. Kathy is also the co-lead of the Get the Medications Right Institute's Payment and Policy Solutions Work Group. Prior to work at ACCP, Dr. Pham served as a senior officer of Drug Safety Project at the Pew Charitable Trust. Her previous clinical experience has been in pediatric pharmacy services, with the majority of the time spent at the NICU clinical specialist and pharmacy residency director at the Children's National Medical Center in Washington, D.C. She's also a board-certified pediatric pharmacotherapy specialist. She earned her Doctor of Pharmacy degree from Rutgers. After completing her pharmacy residency at the University of Illinois in Chicago, she practiced as a pediatric clinical pharmacist and held faculty appointments in various schools of pharmacy, including Long Island University, Rutgers, Creighton University, University of Maryland, and Virginia Commonwealth University. After her presentation, we'll hear from Ann Greiner. Ann serves as the president and chief executive officer of the Primary Care Collaborative, where she's focused on defining and implementing on advocacy, research, and an education agenda that furthers comprehensive, team-based, and patient-centered primary care. She has long been a champion of primary care and the interprofessional team. Ann is a well-recognized leader in the quality field and has worked at a number of prestigious national organizations. Prior to joining the PCC in 2017, she served as Vice President of Public Affairs for the National Quality Forum, where she increased the visibility and influence of NQF on Capitol Hill. She also served as the Deputy Director at the National Academies of Medicine, contributing to the well-known Quality Chasm series of reports and related conferences. She's also held leadership positions at NCQA and the American Board of Internal Medicine. So with that, I'll turn it over to our speakers. Kathy?
Thank you, Katie, and thanks to GTMRX for providing this opportunity to discuss with you today the alternative payment approaches for advancing comprehensive medication management, or CMM, in primary care. Next slide. As we are all aware, the increasing prevalence of chronic disease and complex conditions has profound implications on the growing demand and cost of healthcare. So to address the burden of chronic health conditions in the Medicare program, a shift from fees for service to value-based payment and launching of performance-based alternative payment models intends to reward comprehensive, coordinated care and improvement of health outcomes. The purpose of today's discussion is to highlight opportunities for integrating CMM services to achieve medication optimization in evolving CMMI payment models and demonstration projects. Next slide. Founded under the ACA in 2010, the Center for Medicare and Medicaid Innovation, or CMMI from this point forward with CMS, supports the development and testing of innovative healthcare payment and service delivery models. CMMI is driving a national public-private effort to adopt alternative payment models that reward quality over quantity. And as the primary evaluator of alternative payment models, CMMI is testing approaches to care delivery and payment that are drawn from the clinical experience and innovative practices of healthcare providers and other partners in the healthcare community. Demonstration projects allow the Centers for CMS to test and measure the likely effects of potential program changes, including new methods of service delivery, coverage for new types of services, and new payment approaches. Next slide. Illustrated here is the CMMI process for new models and opportunities for stakeholder input. First, soliciting ideas for new models can be from private sector at the local level or internally at CMMI. CMMI solicits payment changes and service delivery reforms through open door forum and learning sessions. They also can receive ideas through the CMS website idea submission tool. But notably, most models are developed internally by CMMI. In selecting and developing models, input from CMS, HHS, and federal and external stakeholders is included in the review process. CMMI selects payment changes and service delivery model ideas that show promise to improve quality and reduce costs. At this stage, CMMI can engage with other stakeholders to further develop the model, which might be an area of consideration for GTMRX efforts. As CMMI tests and evaluates models, they solicit partners to implement and test new payment and delivery systems models, and they conduct rigorous evaluation of models and makes appropriate modifications as needed, and they assess the appropriate duration, scope, conditions, and populations for these models. CMMI will expand and spread successful models through a variety of mechanisms. One example is the learning sessions they host for partners to share best practices. Next slide. This slide shows the variety of delivery models at CMMI and potential pathways for idea submission. I won't go into these individually, but note that MedPAC has recently called for CMMI to simplify its portfolio, focusing on a smaller set of harmonized models. In MedPAC's regular June report to Congress, it notes that in many cases, providers participate in multiple alternative payment models simultaneously, and Medicare beneficiaries are attributed to multiple models at the same time. This overlapping participation can have unintended consequences. In June of this year, a two-part blog was published in Health Affairs reflecting on the lessons learned from a decade of value-based payment and implications for CMMI. The articles reviewed 12 lessons learned in the last decade, including the need for a value-based payment strategy rooted in a coherent set of core models that enable the delivery of advanced primary care and are reinforced by specialized care models. Another lesson that we probably already knew was that it takes resources and investments to build the organizational competencies needed to redesign care successfully under value-based payment models. I'll highlight additional lessons throughout the presentation where they're relevant. Next slide. The CMMI models we'll discuss today are grouped for you in this slide as state-based, such as the California Wellness Plan and Maryland Primary Care Program, or national models such as CPC Plus and Advancing American Kidney Health. As past and current models inform evolving and future models, this may be better illustrated by walking you through these in chronological order. Next slide. We'll start with the California Wellness Plan. In 2012, California Governor Jerry Brown issued an executive order calling for the development of a 10-year plan to improve the well-being of Californians by controlling costs, improving quality, advancing health equity, and identifying obstacles to improve care. Following this and the subsequent Let's Get Healthy California Task Force report, the California Department of Health drafted the California Wellness Plan, California's chronic disease prevention and health promotion plan. The California Wellness Plan seeks to promote the improvement of chronic disease management, health and wellness, while empowering communities throughout the state of California to achieve equity in health and wellness for all Californians. The 4 primary goals of the California Wellness Plan include healthy communities, optimal health systems linked with community prevention, accessible and usable health information, and prevention, sustainability, and capacity. Next slide. Each California Wellness Plan goal has measurable and reportable objectives that serve as a guideline for efforts to make California the healthiest state in the US by 2022. Goal 2 of the California Wellness Plan aims for health system interventions and efforts to be linked with community programs and clinical services to meet the needs of populations with the largest health disparities. Optimal medication use through CMM aligns with the California Wellness Plan Goal 2 as a preventative clinical service shown to decrease costs and improve outcomes through team-based care and deeper patient engagement. 9 CMM pilot programs were implemented within Southern California, 6 of which are summarized in these next 2 slides. Key findings listed here include patient and provider satisfaction, improved health outcomes, reduced hospitalizations, ED utilization and readmissions, as well as cost savings and cost avoidance. Next slide. And again, we see findings of patient satisfaction and improved outcomes, as well as reduced costs, hospitalizations, ED visits, and readmissions. The positive findings from these pilot programs likely informed the CPC Plus model that launched years later in 2017. Next slide. The Comprehensive Primary Care Plus, or CPC Plus program, seeks to improve quality, access, and efficiency in primary care. CPC Plus is a unique public-private partnership in which practices are supported by 52 aligned payers in 18 regions. This partnership gives additional financial resources and flexibility to make investments, improve quality of care, and reduce the number of unnecessary services their patients receive. CPC Plus is a care delivery and payment redesign model that includes 2 different tracks, with increasing payment and care redesign expectations from track 1 to track 2. Next slide. The framework for transformation includes a progressively advancing set of care delivery requirements with the aim to improve care delivery across 5 comprehensive primary care functions. These are access and continuity, care and management, comprehensiveness and coordination, patient and caregiver engagement, and planned care and population health. CMM and its defined process of care aligns with all 5 of these comprehensive primary care functions, but is specifically organized under the 3rd function, comprehensiveness and coordination, within the CPC Plus practice delivery requirements. Next slide. Over 3,000 primary care practices in CPC Plus fall into 2 tracks with different levels of care delivery requirements. Track 1 continues to bill and receive payment from Medicare fee-for-service as usual and provide episodic care management, including medication reconciliation, to patients following hospital admission, discharge, or transfer, and as appropriate following an ED discharge. Track 2 practices are required to provide more enhanced care delivery approaches to better support patients with complex needs. They receive additional financial support and a greater shift from fee-for-service toward population-based payment. Most notably, Track 2 practices are required to provide comprehensive medication management to patients receiving care management and in transitions of care who are likely to benefit. Track 2 practices are expected to increase the comprehensiveness of care delivered, and they are compensated by the comprehensive primary care payments that should increase the amounts they would have received from fee-for-service payments. This incentive aligns well with CMM, which is inherently comprehensive in its process of care and may support advancement from medication reconciliation or episodic medication management to continual comprehensive medication management. Next slide. These are some of the challenges and opportunities that have been seen from CPC Plus. The CMM implemented in some Track 1 sites when it's actually not required as it was required in Track 2 shows that whether it was through learning sessions, networking, or just Track 1 practices receiving information to show the value of CMM implementation, that regardless of whether it was mandated, that some practices did find that it was the right thing to do to achieve medication optimization. Striking the balance between adaptability for innovation and broader uptake and variability in implementation. This really speaks to the ability to innovate, but also provide enough guidance to have the service delivered with some consistency and fidelity to achieve the value desired. Another challenge that we'll go over in a little bit is the resources for smaller practices, some of them struggling more than the larger health systems or institutions to be able to achieve the multidisciplinary team that is needed for the comprehensiveness and coordination model. And then a concern for sustainability when the model concludes in 2022. Next slide. I won't go into primary care first very extensively here, but while CPC Plus provides the resources to invest in primary care practice transformation, this new model tests these investments and provides performance-based incentive payments. The primary care first, or PCF model, includes voluntary 5-year payment options that reward value and quality by offering an innovative payment structure to support delivery of advanced primary care. And the PCF model options will be offered in 26 regions starting in 2021. Next slide. Building on the CPC Plus model, Primary Care First seeks to enhance care for patients with complex chronic needs and high need, seriously ill patients. CMM most benefits those patients. It also prioritizes the clinician-patient relationship and strives to reduce administrative burden and pay for outcomes. Next slide. The state of Maryland and CMMI established the Maryland Total Cost of Care model that sets the target for total cost of care reductions for Medicare and calls for improved population health outcomes, supported by broad, innovative care redesign between hospital and non-hospital partners across the state. The model hopes to achieve this through its three programs: the Hospital Payment Program, the Care Redesign Program, and the Maryland Primary Care Program, which we'll cover here. Modeled after CPC Plus, the Maryland Primary Care Program is a multi-payer program designed to transform primary care practice with the goals of lowering costs and improving outcomes. While initially for Medicare patients, the program is redesigned to transform primary care for all patients, regardless of payer. It began in January 2019 and runs through December 2026. Its specific objectives are to reduce avoidable hospitalization and ED visits and build a strong, effective primary care delivery system to identify and respond to medical, behavioral, and social needs, while contributing to lower Maryland's Medicare Part A and B expenditures by an annual savings target of $300 million by 2023. Practices are required to provide comprehensive primary care services and include expanding patients' access to care, empaneling patients to providers, implementing data-driven risk-stratified care management, providing transitional care management, coordinating care with specialists, enhancing patient engagement, integrating behavioral health, screening for social needs, and using health information technology tools to continuously improve quality. Participating practices receive prospective payments for these services known as care management fees. Informed by lessons learned from CMMI's CPC and CPC Plus models, the Maryland Primary Care Program seeks to address the challenge for small and medium-sized practices to hire clinical pharmacists, care managers, and other staff. Similar to CPC Plus, the Maryland Primary Care Program also includes 2 practice tracks with the requirement of Track 2 practices to provide access to CMM services for patients receiving longitudinal care. Next slide. The Maryland Primary Care Program, as mentioned, was greatly informed by the challenges of CPC Plus, particularly for smaller primary care practices who struggled with the necessary investments and resources for meaningful practice transformation. So to meet the program requirements, practices have the option to receive operational and administrative support from the Practice Management Office and Care Transformation Organizations, or CTOs. CTOs are private entities that hire and manage the interdisciplinary care management teams that provide care coordination services at the direction of the participating practices. CTOs also offer support for care transitions, standardized beneficiary screening, data tools and informatics, and practice transformation. The primary care program also provided a standardized health information exchange, which includes a free tool to identify patients at risk for avoidable hospitalization and emergency department visits. The CRISP tool uses AI to analyze medical claims, demographics, diagnoses, pharmacy claims, and social data sets to predict events. Connection is key to how both of these elements may advance CMM implementation beyond the progress made in CPC Plus. Connecting smaller practices with CTOs that can help them build the interdisciplinary care for team-based medication optimization, as well as connecting the data to better identify the patients that will benefit most from CMM. Next slide. Small and medium-sized practices can therefore include team members who they would otherwise have difficulty acquiring on their own, such as clinical pharmacists, licensed clinical social workers, community health workers, and data analysts. 24 CTOs are supporting 77% of the practices as of mid-2020. This model also offers state leadership and practice coaching. The Program Management Office offers technical assistance and guidance for practices. They've hired practice coaches who work with participating sites on practice transformation. They hold regular webinars focused on areas of implementation. And additionally, contractors offer staff training programs and webinars. And as you see here, this just illustrates the breakdown of the usage of the care transformation organizations and the size of practices, and how it is really important to address the needs of the smaller and medium-sized practices that are the majority of the practices in this program. Next slide. Like CPC Plus, as I mentioned, Track 2 sites are required to implement CMM. And listed here, and I'm no expert on the payments for this program, but listed here are just some of the examples of revenue opportunities in the Maryland Primary Care Program, including care management fees, performance bonuses, and underlying payments, as well as opportunities for lump sum payments under the quality payment program for advanced alternative payment models. Next slide. To lower costs and improve outcomes for nephrology patients, the HHS announced the Advancing American Kidney Health Initiative in July 2019. The three main goals of this initiative are a 25% reduction in the number of Americans developing end-stage kidney disease by 2030, an 80% increase in the number of new end-stage kidney patients in 2025, either receiving dialysis at home or receiving a transplant, and finally doubling the number of kidneys available for transplant by 2030. Next slide. To further the Advancing American Kidney Health Initiative, CMMI announced a new multiple value-based payment models, 4 voluntary and 1 mandatory, utilizing demonstration projects to test whether payment changes can improve patient outcomes. I'd like to highlight another lesson learned from the last decade, that achieving savings in voluntary models is more challenging than in mandatory models. So we'll keep this in mind as we walk through the voluntary and mandatory models. The 4 voluntary models, or kidney care choices models, were built on the existing comprehensive end-stage renal disease care model, with the goal of improving the transition of chronic kidney disease to end-stage renal disease. These voluntary models focus on kidney transplants and incentivize delaying progression to end-stage renal disease, managing the transition to dialysis, supporting the transplant process, and maintaining patient health after the solid organ transplant. Clinical pharmacists can optimize medications as an integrated team member in a nephrology practice in the Kidney Care First model, or as part of a group of providers, which are the kidney contracting entity in the comprehensive kidney care contracting models. And then of those comprehensive kidney care contracting models, there are 3 payment options: graduated, professional, and global, with different levels of risk and reward. Next slide. The ESRD treatment choice, or ETC model, is a mandatory payment model that aims to test whether greater use of home dialysis and kidney transplantation for Medicare beneficiaries with end-stage renal disease will reduce Medicare expenditures while preserving or enhancing the quality of care furnished to the beneficiaries with ESRD. Next slide. Clinical pharmacists can optimize medications as an integrated team member in a nephrology practice, as mentioned earlier, or in the comprehensive kidney care contracting group or kidney contracting entity. And CMM really aligns with the incentives of these new payment models by addressing medication-related barriers to home dialysis and transplantation, and achieving patient-centered therapeutic goals to slow the progression of chronic kidney disease. And of course, no patient has chronic conditions in a silo, so the ability to manage multiple chronic conditions also adds to the efficiency in patient care. Next slide. The transition from fee-for-service to value-based payments provides further opportunities for pharmacists to be increasingly integrated into team-based care. The rewards for efficient, high-quality patient care provided by the quality payment program positions pharmacists to leverage their training and expertise in collaborative care teams to enhance performance-based incentive payments, increase patient satisfaction, and achieve other practice or system goals. CMM aligns closely with quality improvement initiatives to achieve the national goals of better care, better health, and affordable cost. Although medication management has been tied to transitions of care payment structures, CMM needs to be formally recognized as a compensated chronic care service in evolving payment models. CMM has the potential to help healthcare providers maximize those performance-based payments. Cost reduction, which we talk about a lot, is an important consideration, but we must frame the value proposition for a CMM beyond cost. This is illustrated in a quote from the health affairs piece that I mentioned previously, which notes, in advancing alternative payment models, it's important for policymakers and healthcare leaders to highlight that cost savings is not the only goal of care reforms. As payment reforms allow more flexibility in the way providers deliver care, it's likely that some interventions will add to costs, and not just in the near term. It is still valuable, for example, if a targeted expenditure on social services leads to a significant improvement in quality of life or reductions in hospitalization risk for a patient, even if the cost isn't fully recovered. Patients don't expect their provider to forego a highly cost-effective drug therapy just because it adds to cost. I'd like to conclude with restating that CMM can provide patients with better care, improved access to care, and health equity, and a deeper engagement in their care plan to develop and achieve their patient-centered goals. To advance CMM, primary care practices need to understand where the opportunities lie within evolving value-based payment models and align CMM with the specific goals and incentives of these models. Next slide. And it's my pleasure to turn to Ann Greiner from the Primary Care Collaborative for her reflections and reactions.
Well, thank you so much, Kathy. I really appreciated your presentation, and Katie, your invitation to be here today and to join you all in this conversation. It's really exciting to learn about all the innovation that's going on with respect to comprehensive medication management, both at the state level and also at the federal level. And I think that we've moved beyond just to focus on transitions of care to think about how can CMM be incorporated across the continuum and through all care delivery processes, both primary care and also, Kathy, you lifted up in specialty care. I also really want to underscore your concluding remark that payment is a key lever to further spread and support integration of CMM into primary care. And I intend to talk about that in much more depth, given the title of our webinar today. But first, I'd also like to point out that in addition to payment, I've learned from Paul Grundy, Dr. Paul Grundy, who's the founding president of the Primary Care Collaborative and quote unquote godfather of the patient-centered medical home, that we also need to address two other legs, if you will, of the stool. So payment is one, culture is another, and I think the third is really infrastructure and technology. And I'll talk about those briefly as well. But first, let me start off talking in more depth about the patient-centered medical home and other advanced models of primary care, such as CPC Plus or Primary Care First. There are an array of different names, but I think they are all focused on enhancing population health and really an approach to care delivery that is not reactive to who comes in the door, but focuses on actively working with patients in a healing, ongoing relationship to manage their care with enhanced access and leveraging data and technology. And if you're not familiar with the model, it really was adopted and adapted from a model that the pediatricians have to take care of very compromised and clinically challenging children. They recognized that you really needed to have a way to integrate their care and also a data hub, if you will, to really manage, all of the different encounters they had. And then they applied that more generally. And this model really took off in the mid-2000s and was widely adopted by private payers in the commercial space, by states and the federal government. The latest data that we have is from the AMA that 42% of practices that have primary care either leading or as part of a multi-specialty practice are PCMH recognized. And the principles that undergird the patient-centered medical home, which were updated in 2017, really speak to a lot of the things that Kathy underscored. And I want to draw your attention to those 7 principles of advanced primary care. We call them the shared principles, which are on the PCC website. 350 organizations have signed on to this vision of primary care. And I invite those of you who haven't yet had the opportunity to visit our website, review those principles. And if you are as excited about them as we are, please consider signing on. These principles underscore the importance of the team, which includes the clinical pharmacists, while continuing to emphasize the clinician-patient relationship. So when the principles first came out in 2007, it really was about the physician and the patient. And over a 10-year period, when they were updated and released in 2017, I think we have made the transition to a team-based sport, and recognize that it is really working with a comprehensive team that we're better able to deliver this comprehensive set of services. I think another key principle of the 7 principles is this notion of comprehensiveness, which has long been a part of advanced primary care models. Barbara Starfield, an innovator and noted researcher from Johns Hopkins, who came up with this notion of the 4 C's for advanced primary care. One of them was always comprehensiveness. The shared principles now adds to comprehensiveness this whole notion of equity, because we understand that really to make gains in improving population health and to enhance equity, and yes, to reduce costs and further affordability, we also need to address people's social vulnerabilities, the social determinants of health, if you will. So during the years between the initial patient-centered medical home principles in 2007 and the updated shared principles in 2017, the PCC brought together a group of experts, including Ed Webb, who is then Associate Executive Director from the American College of Clinical Pharmacists, where Kathy now works, to develop a resource, a guide on integrating comprehensive medication management to optimize patient outcomes. And you see a picture of that guide on your screen. And this really was a very important first document to lay out the principles for comprehensive medication management. And it is still absolutely relevant. It came out in 2010, it was updated in 2012, but it is still an incredibly relevant and important foundational document. We've also accompanied that document with guidance for the practice and documentation of CMM in advanced primary care models. So please, in addition to reviewing the shared principles for primary care, if you haven't seen this guide, I would recommend that you look at it. Okay, so back to our 3-legged stool. We've got to achieve these new models for advanced primary care. We need to make progress in the cultural domain, in the infrastructure and technology domain, and also in terms of payment. And I think on the culture front, we can point to a lot of success. As I said earlier, we're now a team-based sport. And we, I think, truly understand the importance of engaging patients and families in their care. We now have patient and family advisors. We now put much more emphasis on shared decision-making and many other ways to engage patients and families. However, we still have work to do on the sort of cultural front. Here's an important data point. In terms of the percentage of patients that have a usual source of care, so that, relationship with, a partner to help you manage your care and to guide you through a complex healthcare system, that's actually plateaued since the ACA was implemented. And you wouldn't think that as we expanded access, you would think that we would have better, more and better and stronger partnerships. And we would see that in the data in terms of the usual source of care. On the data and technology front, for many of you who work in that realm, we've made great strides. And now many practices have access to real-time data to manage population health, which really enables them to participate in risk-based models. However, I also have some concerns there that if we don't truly integrate technology, like telehealth into primary care, we could further fragment primary care. And we also, to a point that Kathy made, need to make sure that we continue to support small and independent practices so that they have access to data and analytics and capital so that they too can participate in these models. We've had a huge transition in terms of loss of independent practices. Now, 7 out of 10 physicians are employed by health systems, health plans, or other corporate entities. And I think we really need to pay attention to supporting those small and independent practices so they can remain independent. All right, now let's talk about payment. I would say this is the least evolved leg of our stool, even though we talk about it all the time. But in truth, while we've learned a lot about how to reform care delivery and experimented with payment models, we haven't actually really progressed markedly in terms of the percentage of revenue that is coming from prospective payment or capitated payment. 97% of physicians rely mostly on fee-for-service payment. And those that have value-based payment, about 36%, most of that payment accounts for less than 5% of their revenue. And that really doesn't move the needle in terms of changing behavior. That's what we've learned from the behavioral economists. We've also learned, I think, over the last 10 years that we can't just take existing primary care payment models and move them from retrospective payment to prospective payment. We need to invest. And there's 2 forms of investment. There's that upfront investment to have the infrastructure, the capital to be able to build out your team. And then there's the ongoing investment at a higher level for all that we want primary care to accomplish. Because currently in our country, we average about 5% of spending is on primary care. That's at the same time when we're looking for primary care to deliver this more expansive set of services, integrating mental health and integrating oral health, integrating comprehensive Medicare management, integrating and being responsive to social vulnerabilities, all on 5% of the dollar. And in fact, that primary care spend has been declining. So clearly we've got a lot of work to do there. I will say one note, states have been making some progress in putting more dollars into primary care. 13 states are now requiring health plans to report what they're spending on primary care. And 6 states have set increases in investment in primary care into advanced primary care models. So I don't mean to be a downer, though. I think actually the context has shifted and we have an incredible window to make some bold changes on the payment front that can help facilitate CMM. Our policy window, I think, has never been better since leading up to the ACA. And what's contributing to this more favorable policy window? Well, we've got an administration who's very committed to equity. And you don't get to equity unless you've got strong and robust primary care. We also have this incredible evidence base that just came out from the National Academy of Science, Engineering, and Medicine, that if we put more resources into primary care, we're actually going to improve population health and equity. No other part of the healthcare system can say that. And these recommendations, particularly on the payment front, are really being embraced by the community. And I think we can be very excited about that. Also, COVID was really challenging for primary care. And I think primary care clinicians are ready to make some bold changes. They suffered a lot, $15 billion in losses in 2020. And fee-for-service payment didn't really work when nobody could come into their offices. A recent survey from the Green Center showed that 46 of primary care clinicians want to move to a majority prospective payment. That's remarkable. I really think we've got a lot to work with there. And also patients themselves are telling us that they want whole person care, one-stop shopping, integration. They don't want to, run around and try to get the care. They want it to be integrated and seamless. So what can we do to reform primary care payment and financing so we can foster more comprehensive care, including integration of CMM? One thing I would encourage you to do is join the PCC. We are engaging in a broad-based coalition to advocate for the kind of primary care reform and investment that will allow us to get to a more comprehensive set of services delivered by a team, including CMM. We're going to have a working summit with our executive members in November and select guests, and we're going to be focusing on policymakers at the federal level, principally Medicare, to really advocate for some bold changes in payment. Stay tuned for a more public campaign in 2022. I also think that we should continue to focus on shaping CMMI, primary care payment models, and Kathy gave us a lot of fantastic background there. Beyond primary care first, CMMI is poised to come out with a new primary care model, and we'll want to try to shape that moving forward. I also would recommend that we get a better understanding of what patients want from these integrated models. We have some research about what they want, but not enough. And I think we need to build on work that some have done, like Community Catalyst, to understand, particularly from marginalized and vulnerable communities, what do they want from primary care? What do they want from CMM? That would be a wonderful set of focus groups to do. Again, I've mentioned this earlier, we need to look out for those small and independent practices and figure out how to support them. And finally, I would remind you all, and many of you know this because you were involved in the PCMH movement, that it's going to take a village to achieve bold, transformative payment care. Those that are benefiting from the current status quo are very powerful in our health system, and they don't particularly want changes. If we want to make changes, we have to come together with a single ask and a unified vision, and we need to engage in team-based advocacy to achieve it. So thanks so much for the opportunity, and really look forward to the conversation and the questions.
Thank you, Ann. Those were wonderful responses to Kathy's terrific presentation, and we appreciate your perspective and Kathy's perspective. So we'll move on to a few questions that we've received from the audience. Let me ask this first question to Kathy, you and Ann both. In what way, and Ann's done a good job of outlining this in her remarks, but in what way can we advance the physician's understanding of the value and utility of comprehensive medication management to optimize medication use in practice?
Do you want me to start, Ann? I see you taking a sip. I think that what we've seen from the progression of these models and how some of the lessons learned have carried forward, the fact that CMM has kind of retained some implementation requirement in evolving models, I think that there is some baseline understanding there, and there is some acceptance of a value proposition. I think it's just those that, we kind of talk about the range of those practices that are completely CMM naive, or those who are CMM curious, or those that are just doing what they can but wanting to really fully optimize their CMM services. I think that's a little bit difficult sometimes when we're talking to these audiences, to get a feel, even at the practice level, like where is that practice at? And then within that practice level, if it's a group of providers, what is each physician's understanding of that? It can vary, across the system or even within a practice. But I do think that there are certain themes that everyone can identify with, and there are challenges that everyone is struggling with. So to understand the value and utility of CMM in practice, it really needs to be offered as a solution to the provider burnout and the workforce shortage, a solution to the ongoing need for better team and practice efficiency, a solution to the challenge of having patients reach their targeted goals and having a real partner in that, so that the onus isn't any on one particular individual of the team, and really understanding that CMM goes beyond adherence and that there's unrealized value that could be bringing in not just performance-based incentives, but better patient outcomes. That's really what we're trying to make this about, the patients, not so much chasing what CMMI's, incentive payment goals are. But, obviously sustainability is important, but we have to do what's right. And that's to ensure that this population that has so many chronic conditions that consume so much of the health care demand, including costs, that they're actually getting better, so that we can keep them out of the hospital, out of the ED, just being able to make them healthier. And also to better predict outcomes for, future pandemics and other things down the road. I think that just the long haul COVID, there's going to be a lot of need for primary and specialist care. And, if everyone can be healthier, that they will also be able to respond to future health challenges affecting population health in the future.
Anne, do you want to weigh in on that?
Well, I think that's Kathy said a lot there, and I wouldn't disagree with a word of it. I think part of our challenge is that we still train our professionals mostly in silos, and so fortunately, a lot of physicians don't really have how working, in a team-based manner can really enhance their ability to meet patient needs. Reforming health professions education is a whole other very, complicated, and I would suggest even more challenging than payment. I think it's a system that hasn't changed much. I think another challenge for us is that primary care can barely lift their heads up. It's 2 hours of documentation for every 1 hour of care. The hamster wheel seems to go faster and faster every year. So a 15-minute visit is not enough time really to thoroughly discuss this new medication and to figure out how it fits into all the other medications that your patients are taking. So, it's coming back again to, we've got to reform that payment model. So the focus is on patient outcomes. If the focus is on patient outcomes, you're going to have longer visits because you can't possibly deal with the complexity of some of your patients. And you're also going to provide care in so many new and creative ways to try to optimize those patient outcomes. So I'm very optimistic that if we change the payment model, we're really going to make some headway here.
So thank you, Anne, for those comments. And both of you know, Kathy, you and Anne both know that we're kind of living in two worlds. And you really did a good job of presenting some of the figures in terms of the percentage of total revenue that physician practices receive from alternative payment models and the challenge there. But while we live in these two worlds, how do we encourage the shift from the fee-for-service world to that value-based care world and develop a business model? And Anne, this was discussed on our recent executive roundtable by Alan Oral. But how do we do that and ensure that investments are there to prepare us when these alternative payment models are available for these interprofessional team-based models that make a difference and have an impact?
It is challenging. I mean, we feel like we are living in the proverbial two canoes. So we just finished up, and I think ACCP and many others that sit around our virtual and in-person tables contributed to our comments on the Medicare physician fee schedule. So we're really trying to affect that because that is how we're paid. At the same time, making the argument to policy leaders that, we continue down this path of undervaluing primary care and the investment levels continue to decline. The platform cannot hold. It got quite shaky during COVID. And if that platform is not there, we will not be able to make gains in terms of population health, because primary care needs to be there to partner with patients to help them change their behaviors, to help them manage these complex conditions. If we don't have that front door, how will that happen? I mean, hospitals are not set up for that kind of care. So, we have to be attentive to this. And, we are making this case about if we want to get to equity, if we want to get to comprehensive care, we need a team and we need to finance that team.
Kathy, did you want to, I've got another question for you, Kathy, unless you wanted to respond in another way there.
I think I'll just add that, I think that it's a little bit of a chicken and egg situation, right? Like, are you waiting for practices to want to be in value-based payment to move the payment model forward, or are you going to have the payers have more value-based payment models available to encourage practices to participate in those models? And so I had read previously that, you know, about a third of the commercial payers have in their portfolio alternative payment models, but the critical point is really 50%. So from the payer side, we still have room to go, but also from the practice side, I think that the pandemic has brought to light how non-sustainable fee-for-service could be in the future. And so I think that both kind of see evolving goals to get there, and how much quicker that need has been identified, I'm not sure, but I'm hoping that in this last year or so that we've seen more of that, why we should be shifting to value-based payment than previously.
Thank you. Now, I know neither one of you are technical experts as it relates to payment development of the payment methodologies, but we have a question from an audience member that asked, how would you recommend that we capture return on investment data in our medical group for application of CMM in practice? Either one of you want to take a swipe at that, or?
Go ahead, Kathy.
I actually think that was another kind of issue with the previous question, is how do you shift? I think that that's the thing. We need better metrics, knowing how to, whether it's to capture ROI in a way that matters and is more broadly applicable to incentivize payers, whether public or private, but also to identify the outcomes that will matter to these broader stakeholder groups. So I think that there are, you know, in our evidence resource document from GTRMREX, there are a couple of different ways people looked at cost. In that, even in the California Wellness Plan, you saw a couple of different ways people talked about cost savings or reduction of costs. So I think that right now the ROI data, broadly speaking, when you look at it in terms of the bigger things like the reducing ED visits and hospital readmissions or hospital utilization, I think that that's sometimes harder to have accountability or attribution when it's a particular service provided by the team compared to how the practice has performed broadly in these bigger metrics. But I do think that that's a challenge, and I'm hoping that there will be evolving guidance in what is the best ROI data to make that case.
And of course, we have work groups within the Institute that are working on not only metrics, but the gaps in measurement and outlining the importance of ensuring that. And at the same time, use cases that, as you said, those use cases outline how they were able to measure both clinical gains and cost of care, the results from that end. We are nearing the end of our time, but Anne, I wanted to give you an opportunity to comment on that if you would like, before I ask each of you to give us a concluding remark.
I would like to comment. Kathy made a point that we shouldn't just look at costs. We need to look at value. And I think to our peril, we have focused too much on costs. While the other sectors, spend in the other sectors has continued to go up, and we are getting no better outcomes in terms of life expectancy, and our costs rise. So, I think a hard look needs to be at, this investment in the part of the system that the evidence shows can deliver better population health outcomes and more equity. And it may not be, we cannot expect there to be an overnight ROI. I'd prefer for us to be looking at the 10-year CBO window, where you actually get primary care at the center of the delivery system, as it is in every well-functioning health system across the globe. Then they're in the position to really deliver on ROI and really be accountable for total cost of care, but not until they're in that kind of position. So, the National Academy of Medicine report really pushed back on this notion of delivering on ROI, particularly in the short term. And I think, it's a real conversation that we need to have in our community.
Thank you, Anne. At this time, I'd like to thank you and Kathy for your presentations. Ann Greiner has been a friend of the Get the Medications Right Institute since we launched the Institute. And Ann, we are very grateful for your support and participation in a number of our executive roundtables. As I've mentioned before, Kathy Pham has been a leader of payment and policy solutions work group of the Institute, and we are certainly fortunate to have her leadership as part of that group. And I'll give you a few seconds to offer some closing remarks, and Kathy, I'll ask you the same. And for those that are on the line with us today, after they offer the closing remarks, I'll thank you for your participation. So, Ann?
Thank you very much. I'll be incredibly brief. Join us with team-based advocacy to strengthen primary care, and we will work to incorporate CMM into our payment models so that we can make the difference we all want to make in terms of patient outcomes, equity, and affordability. Thanks.
Thanks, Ann. And I will just add that I see a lot of questions coming from clinical pharmacists in the audience about the how. And I will just say that don't wait to get invited. As we see these models are moving forward, some remembered CMM, some did not. And I think it's just, as we've done throughout the history of our profession, where we've had to help others understand how we can contribute to team-based care to achieve these goals in medication optimization, utilizing services like CMM. I also see precision medicine. These are tools, and that you want to invest in integrating the right members of your team to best utilize these tools to get the right meds to the right patient, the right time, the right dose. It's not just about using a suboptimal regimen correctly. It's about making sure that we have all of what we need to make the most informed choices for our patients.
Thank you so much for both of you. That marks the end of today's event. And on behalf of the Medications Right Institute, I'd like to thank our speakers, Kathy and Ann, and the audience for joining us today. One of our audience participants said, lean in, and we encourage you to join not only the patient-centered collaborative, but the Medications Right Institute in supporting and advocating for interprofessional team-based care that will optimize medication use through CMM in practice. Please fill out the survey that you'll be receiving after the webinar today. A recording of this webinar will be posted 1 week within this, and there will be a follow-up issue brief, and we will attempt to answer some of the questions that you have asked that went unanswered during our Q&A period. To stay up to date with the Medications Right activities, make sure you follow us on Facebook, LinkedIn, and Twitter by searching GTMRX Institute. Thank you for joining us today, and have a wonderful day.